Today, we are on site at the World Center Marriott at the 2020 Transplantation and Cellular Therapies in Orlando, Florida. We are recapping some of the top news that has been presented during the conference, and soon we'll speak with Dr. Sergio Gert on transplant-associated thrombotic microangiopathy, as well as Dr. Nelson Chow on endothelial injury syndromes that arise from transplantation. Welcome to Enclave News Network. I'm Gina Columbus. In large B-cell lymphoma, an analysis of 3 studies showed that outpatient administration of CAR T-cell therapy with lisocabtagene maraleucel is safe and effective in patients with relapsed refractory large B-cell lymphoma. The results show that outpatient treatment in these 3 studies, which were Transcend NHL 001, Pilot, and Outreach, demonstrated comparable clinical outcomes and toxicity as treatment across all patients in a pivotal trial of liso-cel conducted at university medical centers. In retrospective analyses presented at the meeting, ruxolitinib was found to be an effective and well-tolerated treatment in the refractory setting for patients with chronic graft versus host disease, regardless of age. Currently, the only established first-line approach for patients with chronic GVHD is treatment with steroids. Therefore, ruxolitinib provides a good alternative compared with other treatment approaches in this difficult-to-treat patient population. In the Phase 3 Sierra trial, preliminary data showed that treatment with iodine 131I apapistamab, known as IOMAB-B, conditioning induced a complete remission in 84% of patients with active acute myeloid leukemia. These patients were then able to receive allogeneic hematopoietic stem cell transplant. Findings showed that 18% of patients who were treated with conventional care reached the same result. Moreover, rates of non-relapse mortality at 100 days following HCT were lower in patients treated in the IOMAB-B arm at 6% and in those who crossed over at 10%, compared with patients who received HCT after standard therapy, which was 29%. An analysis of the Phase 1-2 ZUMA-1 trial showed that early steroid intervention could reduce the severity of adverse events associated with axicabtagene ciloleucel in patients with refractory large B-cell lymphoma. With a more rigorous AE management protocol that involved earlier steroid and tocilizumab administration in patients with symptoms of cytokine release syndrome and neurologic toxicity, lower rates of severe events were seen in expansion cohort 4 of the trial versus combined cohorts 1 and 2. All-grade CRS was observed in 93% of patients, each in cohorts 4 and 1 and 2. However, grade 3 and higher events were lower in cohort 4 at 2% versus 13% in cohorts 1 and 2. Corresponding rates of all-grade neurologic toxicity were 61% and 64%, with grade 3 and higher events of 17% and 28% respectively. An off-the-shelf Epstein-Barr virus-specific cytotoxic lymphocyte CAR product derived from cells harvested from third-party donors induced a 100% response rate in adult and pediatric patients with relapsed refractory non-Hodgkin lymphoma. Results of 2 cohorts were presented from the Phase 1 trial. Cohort 1 included patients with relapsed refractory disease following allogeneic hematopoietic stem cell transplant and patients with relapsed refractory B-cell malignancies who were eligible for autologous HCT were included in cohort 2 and also received CAR T-cell therapy consolidation after transplant. Results showed that responses in cohort 1 occurred in 57% of patients and in 100% of patients treated in cohort 2. 83% of those treated by third-party donor cells had a response, and all patients with chronic lymphocytic leukemia and non-Hodgkin lymphoma had a response, compared with 40% of those with B-cell acute lymphoblastic leukemia. Good morning. We are here with Dr. Sergio Gert. Sorry, let me redo that. Good morning. We are here with Dr. Sergio Gert, who is the hematologist oncologist and chief of adult bone marrow transplant service and Melvin Berlin Family Child Multiple Myeloma at Memorial Sloan Kettering Cancer Center. Hi, Dr. Gert.
Hi, Gina. How are you? Good morning.
Good.
Welcome to Florida.
Yes, welcome. So let's talk a little bit about the meeting that's taking place here in Orlando. So there's a variety of intriguing data being presented at this year's meeting. What findings are you most intrigued by?
Well, this is the largest meeting regarding transplant and cellular therapies. It's held every year. We had 3,900 members coming to the meeting today from all sorts of disciplines: nursing, social workers, advanced practice providers. So there was a bit of everything. I think the meeting this year focused on cellular therapies, CAR T cells, and it also focused on the toxicities of transplant. This morning, for example, we had a breakfast symposium talking about thrombotic microangiopathy associated to transplant, an entity that we call transplant-associated thrombotic microangiopathy, in which there's been a lot of changes over the last couple of years. One of it is I think we are an increasing awareness that it's just much more common than what we thought about. One of the things presented in this meeting was that initially it was thought to be a very rare complication, less than 2%. But data is emerging more and more frequently that if we actually look very at strict criteria, the incidence of TA-TMA may be up to 20% of all patients. And this is much more common in the pediatric population than in the adult population.
Very good, thank you. Now, looking back at the presentation that you just gave this morning, what would you say are really the key messages you want the audience to take from that?
So I think the first key message is, and particularly it is due to the pioneering work that Stella Davis in the Children's Hospital in Cincinnati and Dr. Jondell and now Dr. Dandoy have done, in which they've prospectively looked at all patients who are undergoing through transplant to see how many of them develop what we call TA-TMA. By looking at daily labs and then looking at weekly urines, they've identified that up to 20 to 30% of patients develop increased schistocytes, increased creatinine, decreased platelets, and presence of protein in the urine. And this constellations of syndromes is a hallmark of endothelial damage. And we recognize TA-TMA is one of the endothelial damage syndromes. Amongst those patients that develop that complications, some of them go on to develop the severe form of TA-TMA, which interestingly in children has different manifestations than an adult. In children, they can cause, pleural effusions, it can cause pulmonary hypertension, it can cause neurologic abnormalities. In adults, it primarily causes neurologic abnormalities and renal failure. So I think this distinction about pediatric TA-TMA and adult TA-TMA, and more importantly, the fact that we need to be more aware because the pediatric population has shown, I would say, dramatic responses to complement blockade antibodies, such as eculizumab and narsoplimab.
That's some great points.
Yeah.
Now, can you alluded to this earlier, kind of speaking to the underdiagnosis and under recognition really of this condition, and what are some of the long-term effects of it?
So it's interesting that the Center for International Blood and Marrow Transplant Registry, the CIBMTR, recently did a retrospective analysis of how many patients developed TA-TMA in a large group of adult patients. And that number was 2%. And we were surprised because we really think that we see this more frequently. We recently went through our database at Memorial Sloan Kettering, and doing a retrospective review, we saw less than 2% of the patients being diagnosed with something that would be like TA-TMA. But when we look at the screening criteria, almost 10 to 12% of the patients would actually screen positive for possible TA-TMA. So I think we're definitely underdiagnosing it, partly because the criteria are still very diverse. There are no uniform criteria. And I think that we need to increase awareness so that we can diagnose it earlier, so we can understand the spectrum of the disorder and understand which patients need to be treated, and more importantly, understand the pathophysiology. Why does this occur? The people we've postulated what we call the triple hit hypothesis. You are predisposed to this because of polymorphisms. You get a toxic stimuli, such as the conditioning regimen, and then something else happens that damages the endothelial and triggers what we call thrombotic microangiopathy, which is a fancy word for your blood cells are being destroyed because there's a local destruction of the endothelial cell.
Wow, okay. Now this study you just spoke of with the 2%, that's the prospective screening study that was discussed at this year's?
So the prospective screening study is what the Cincinnati people have done, and in that case, the incidence is up to 30% because they're looking for it every day.
Wow, okay, a lot.
Yes.
So it's much more common than we really realize.
It's much more common than what we really think.
All right. Now, what strategies are being evaluated to improve some of these outcomes for TMA? For example, there was a retrospective study, as we discussed, with early initiation with eculizumab in this population. So could you talk about this trial a little bit and the results and what challenges we might still have with that approach?
So it's interesting. A lot of the results of the prospective screening trial that was done by Cincinnati and the pediatric oncologists have shown that early intervention with eculizumab may make a difference. We don't know if those results will translate into the adult population. Because again, as I've stated, many of those patients were treated for non-neoplastic disorders, for hemoglobinopathies, for immune deficiencies. And in the adult population, we treat primarily malignant diagnoses. So I think the first thing that comes out of it is that in the pediatric population, complement activation that is inhibited by eculizumab may actually be an important contributor to the entity. We don't know if that's in the adult population. The same, and a group of us in what we call the TATMA working group are thinking to see if we should follow the example of the pediatricians and start doing more aggressive screening for TATMA, so see if we can understand this disease better.
Very interesting. Is there anything more you would like to expand on from the pediatric aspect of eculizumab?
So I think the important thing is that our pediatric colleagues have shown that eculizumab is safe, that it needs to be dosed according to the activity, because the more complement activation, the more drug gets consumed and the more you need. And they have created algorithms to be able to do what we will call rational dosing of eculizumab. But I think it's also important to recognize that we don't know if the same results we get in pediatric population will get in the adult population, and therefore prospective studies are needed.
Great, thank you so much.
Thank you very much, Gina.
So what are some of the other data that we're looking at or that we've seen to try and improve outcomes with patients with TATMA? So if you could expand on the complement inhibitors, OMS 721, of course.
So there is narsoplimab, which inhibits complements through the lectin pathway. I think, if we're looking at one is early recognition, two is recognizing what the triggering event is and addressing the triggering event aggressively, whether it be a viral infection, calcineurin inhibitor toxicity, or graft versus host disease. And then, if there is evidence of complement activation, treating with a complement inhibitor, preferably in the context of a clinical trial.
Great. Now, I do want to quickly just focus on the endothelial injury syndromes. So could you discuss how this condition occurs and how frequent does it occur following transplant? How do you manage it?
So it's very interesting. We've now recognized that a spectrum of complications that have to happen after transplant are all due to damage to the endothelium. It goes from fluid overload, described by the group at MD Anderson, rapid increase in weight early post-transplant, which is also known as capillary leak, idiopathic pneumonia syndrome, thrombotic microangiopathy, sinusoidal obstructive syndrome. And we think that all these entities have in common, or the first event is endothelial damage due to the conditioning regimen. I think one, awareness is important. Two, strategies that may protect the endothelium will be very important, and whether narsoplimab or eculizumab or defibrotide or other agents that have been proposed to protect endothelial damage will be important to continue to explore in prospective trials. We need to remember that although relapse remains the most important cause of treatment failure, transplant-related toxicities still cause 10% of deaths in patients, and we really want to get that to less than 1% and preferably zero.
Absolutely. Were there any studies presented related to endothelial injury syndromes at this year's meeting that you think should be highlighted?
There are a variety of posters, very interesting, looking at risk factors, and other posters confirming that there is some patients who may respond to eculizumab therapy.
Great. Dr. Jarrell, thank you so much for being
You're
here today.
welcome, Gina.
Really
thank you very much, and enjoy Florida.
You too. Thank you. We are here with Dr. Nelson Chow, who is the Chief Division of Cell Therapy in the Department of Medicine at Duke Cancer Institute. Hi, Dr. Chow. Thank you so much for being here today.
Sure. Morning.
So there has been a lot of really interesting data being presented at this year's meeting. Would you mind just sharing some of the highlights of what you're really excited about?
This meeting's always been very good on the science. I think there's been a lot of interest still in graft versus host disease and new things coming through. CAR T cells, of course, and novel preparatory regimens. A lot of fun things.
A lot of fun things, definitely. So I want to focus on endothelial injury syndromes post-transplant with you. So could you discuss kind of the instance of this, the underdiagnosis, of course, and what are really the key challenges with this condition?
So I think over the last probably 10 years, we're starting to realize more and more that the endothelium, which obviously covers everything, covers all our blood vessels where all this immune cells traffic, is probably one of the major areas where we've been neglecting to focus on. So I think in the past, probably 3 to 4 years, more and more of us have recognized just how important the endothelium is, both as a target for disease as well as a way to mitigate these toxicities.
Great. Okay, thank you. What would you say the role of endothelial syndromes is in graft versus host disease, for example?
So that's an area I think we're starting to focus more and more. I think the focus in graft versus host disease has been on the effector cells, appropriately so because the T cells cause graft versus host disease or acute graft versus host disease, but we've not focused as much on the environment, which is where we think a lot of the impact of those effector cells occur.
Interesting. What would you say are some other unmet needs when it comes to endothelial injury syndromes?
I think there's a lot of toxicity from the preparatory regimen where we need to figure out how to mitigate that as well.
Got it. Okay. So there's a study that's actually being presented this year's meeting on circulating endothelial cells as a marker for vascular injury in pediatric patients. Would you be able to discuss this trial a little bit and what the findings showed?
So the interesting part is you can tell these vascular endothelial cells come from the bone marrow and they populate injured blood vessels. And so you can count these vascular endothelial cells and get a feel of sort of what the response is. In many ways, not dissimilar to neutrophils counts going up in an infection. You can actually do flow cytometry and look at these cells and get a sense of the bone marrow response to vascular injury.
Oh, interesting, thank you. So another really interesting study was we're learning about a 100-day Ecig Score that can be used as a predictor to identify those who are at increased risk of poor outcomes after transplant. So would you be able to expand a little bit on this tool and the data supporting it and how it could potentially impact clinical practice?
So it's a very interesting score which takes the LDH multiplied by the creatinine and divided by the platelet count. So the LDH is a poor man's marker for cell toxicity. Creatinine is sort of a reflection of both kidney function as well as tissue damage. And platelet count is probably one of the early predictors of endothelial cell injury as platelets go to repair the endothelium. So it's a way to get a sense of what the damage level is at the body at any particular time. And it's been, I think, quite interesting to think about using this. Most of the data has been retrospective at this point, so we do need larger prospective data to see how good these things are in real time.
Thank you so much. I do want to focus a little bit on transplant-associated thrombotic microangiopathy as well. Are there any data related to this specific condition that were interesting at this year's meeting?
So there's been a lot more interest in TMA, and the interest is really reflecting on there might be potential things one can do. So TMA has always existed out there, but there hasn't been a whole lot of therapies. So now that there are at least two, and maybe more, there's, I think, a greater interest in how to define it and how to detect it. So I think there's going to be a lot of more work in that area.
Could you expand a little bit on the treatments that we're looking at, the complement inhibitors, right? So we have OMS721, isiluzumab, what we're seeing with those agents.
Yeah, so eculizumab has been around now for a while for this, and it's been the go-to for patients with bad TMA. The OMS product it works a little differently, and so there's a lot of interest in sort of learning how to use that more. I think what we're going to need to do probably is to have a better definition of what TMA is, and if we wait till the patient is quite sick, the outcomes are probably not going to be as good.
And that's another challenge with this condition as well, right? There's a lot of underdiagnosis.
Yes, correct. So I think we're going to have to figure out how to define it better at an earlier time point.
Well, Dr. Chow, thank you so much for being here today. I really appreciate you sharing all this insight.
Good.
Great, thanks. That's all for today. Thank you for watching Enclave News Network on location at the 2020 Transplantation and Cellular Therapies meetings. Signing off from Orlando, Florida, I'm Gina Columbus.